theme song. Oh, look, it's already recording. Tia, can you hear us okay?
Yes, yes, I can hear you guys. I can hear you now. Now I don't hear you.
Okay. Well, we have a microphone too, so you guys will be able to hear us all very well. I'm going to turn you to face the group, I guess. No, hang on, I gotta make it not blurry.
Yeah. You know what? She told me that. Yeah.
You guys are missing out if you're virtual. We have fresh fruit and fresh cookies, milk, tea, water, and a bunch of fun swag and brochures. So next time, hopefully you can make it.
You're right. We are missing out. All I have is my bottle of water that's now empty.
Oh, well, you definitely have time to fill it up if you're.
Yeah.
Everybody's running late as usual.
I love that.
Okay, good. How are you? You ready? I think so. Well, you can sit here. And you can see, have you guys met?
No, I haven't.
I know, Chrissy Keller. Yeah. So you're our Medicaid and you're our Medicare. Come on.
Oh my gosh.
Wow. Cool.
Yeah, that's awesome. Good for you. It's kind of, I just take around it. Yeah. So I don't know, kind of what the format, we'll let her kind of just do her thing, but yeah. If you have anything to piggyback on what I say or like, that's perfect.
I'm familiar with Medicare.
Okay.
We have a lot of
Perfect. Okay, awesome. Well, I'm like really excited. I just specifically do the Medicare side of everything. So I'm really excited to hear what you have to say too. Yeah. Good. Okay.
Here, I'll let you sit here.
Okay.
And then, so they can hear you through that.
Sure.
And then I also
Yeah.
have, a microphone.
Sounds good. I'm gonna take
Hi.
Sorry, I didn't really speak. I'm sorry, but good to see you.
Gave your card these to another family. Right. She's on United Healthcare now,
Okay.
but I explained it to her.
Yeah.
It's really neat.
Yeah.
Over to United Healthcare or other options.
Happy to be back.
Oh, that's good. I'm happy on it.
Oh my gosh.
Yeah. It's very cool. Yeah.
Trust myself being close to this cookie. I can smell them.
Really? And I don't know how that. And so how I knew like that. Yeah, I'm sorry. Really? They show them our names. I don't even know. I still.
Oh, for sure. I mean, they do that a lot.
Okay, we're gonna get started here in just a minute. I'll find your seat. Make sure you have your snacks. We're fully equipped this time, you guys, with all the technology. Is that too loud? Not loud enough? Everybody in the back can hear? Okay. Everybody online, you can hear me okay? All right, thanks, Kim. I'm Courtney Stryker with Arapahoe County Senior Resources and Veteran Services, and I'm the chair of ACCOA. So just a couple housekeeping before we get started, and we will do maybe introductions at the end so the people online don't have to sit through that. But I know that we were talking about doing some service projects for the year of 2025, and I wanted to bring some of the items that we have come up and see what everyone's interested in. These are two sponsorship opportunities. This year we have already sponsored age-wise. Colorado, but there is the Alzheimer's walk that we can sponsor. It's a little pricey. The lowest sponsorship level for the Alzheimer's walk is $1,800. However, we also could develop a team and fundraise and walk. So if that's something people are interested in, we do need to have 2 captains that help recruit people and train them on how to do the fundraising and keep track of all of that. So if that is something we're interested in doing, we can discuss that further. And then another sponsorship opportunity that came up is with the Aurora Center for Active Adults. There's an opportunity for $600 to sponsor 17 of their events. We get a table at all of their events, so like outreach, those types of things, recognition, and our logo on all of their event items. So that one is option 1, and then there's lower options if we didn't want to do the full $600 sponsorship. So I just wanted to bring those forward. Think about it. We can vote on it later, but just for service projects wanted to do that. So today, as mentioned, we're both online and in person. So people online, you are connected to a very loud speaker. So if you yell, we should be able to hear you. But if you can't hear us, just wave your arms and I'll try and see what's going on. But today's presentation is Medicare and Medicaid 101. I asked Steve and Krista to just do presentations to educate us on what these look like. And then we are recording the Zoom so that we can share this to other individuals who couldn't make it. So this is Krista Keller, this is Steve Nash, and do one of you have a preference on who goes first?
I can, yeah,
All right.
sure.
Krista is with Medicare, and I've watched her in action. If you haven't worked in tandem with her, she knows her stuff. So there you go.
That's nice, thank you. I brought handouts. Do you want to do those? Do you think? Okay, sure. So, thank you. I like those, but, so I'm Krista Keller. Most of you guys know me. I'm also the vice president of ACCOA and have been on the board for, I would say, at least 10 years. So I love this group and I'm so glad we're like back in person, but also have this hybrid option. So all good things. So I have been a Medicare insurance broker for a very long time. I think 18 years in my industry. So I do know a lot about Medicare. What I have here today is just an informational booklet. Like I said, I'm a visual person. So a lot of times when I do Medicare 101s to my clients and their families and all of that, I like to just have something to look at. So if you want to, let me right here. If you want to turn, this is just a guide that one of the many insurance companies that I represent puts together. So if you want to look at page 4, that was primarily what I was going to focus on today. Oh, sure, I have plenty. Okay. Certainly, we have everybody else come out too. So hi. So yeah, this is just basically like, again, when I do Medicare 101s, I do them all over the community, libraries, assisted living, like Barb just came in, I go over and do those at River Point sometimes, Libby Boards I've done in the past. So if you ever want me to come and do kind of similar type of thing, we can do that at any point in time. But yeah, just to kind of give you an overview of Medicare, and then we can kind of talk about how that fits into Medicaid as well. So Medicare is a government program that typically people get at age 65, but people can also get Medicare under age 65 due to disability. So you may run into people 20s, 30s, 40s, that also have Medicare, and it's because they've gone through a court system process and have been granted disability and therefore get Medicare, which usually comes 24 months after they get the disability, which I know is a long time and kind of unfortunate, but that's the rule. So Medicare A and B is like your basic Medicare government coverage. So the A as an apple is for hospital coverage. This is the one that typically comes at no cost because people have paid into Medicare during their working years, and therefore there's no cost associated with that. So sometimes when people take Medicare at, are eligible for Medicare at 65, but also have a group plan, sometimes they'll just take Medicare Part A and keep their group plan because Medicare Part A doesn't cost anything. In most cases, it's like you might as well just take it. And then a lot of times I'll have the conversation on comparing what somebody would get with a group plan versus what they would get by transitioning into Medicare. Sometimes it's very obvious, like keep that group plan as long as you can. Other times it's like, actually, you could save some money or maybe have better coverage by transitioning into Medicare. So again, that's just one of the many conversations that I have with people and helping guide them in the right direction. So the Medicare Part B, as in boy, is going to be the physician and outpatient services. That one typically does have a monthly premium of $185 per month. So that's kind of like the standard premium. So again, a reason for sometimes people who get insurance elsewhere to maybe opt out of Medicare, and they can do that as long as they have credible coverage from the time they first turn 65 until they transition in. So let's say somebody's going to work until they're 70, as long as they have a group plan from 60 per month until they want to transition into Medicare when they retire, they can do that without penalty as long as they have continuous coverage from a credible coverage, meaning that it's like a big insurance company, like Aetna or Cigna or something like that. It's not like a discount program that's not through insurance. The other thing to keep in mind with the Part B premium is that it is adjusted based off of income level. So if you know of folks who are a higher income level, maybe they are finishing out their career and have a good earning for those last couple of years, that can actually be adjusted. So maybe rather than paying $185 a month, there's actually a grid, and I can definitely get my cards are over on the people. So I can definitely get that to you if you're ever interested. It's just basically a certain adjusted based off of the tax bracket that people could maybe pay more than $185. The other piece with that, we'll kind of get into this with the Medicaid part, but there are government programs that help that premium on someone's behalf if they're not able to afford it. So these are going to be lower income folks. There's a federal program. He's going to talk about state Medicaid, but there is a federal program called Extra Help, which is a subsidy that helps people pay some, if not all, of that $185. So for somebody who's struggling and is like, I cannot afford an extra $185 a month, that is a really good way to get some help with that. So people always across the board, people always ask me, like, what type of people do you work with every day? I'm like, everybody, because everybody's on Medicare, unless you get insurance elsewhere. I mean, high income, low income, all sorts of backgrounds. So it's really hard to navigate. And that's why, we have resources here to make sure people understand. So basically beyond that, step 2, kind of at the bottom of page 4 there's 2 different options that we look at when we're deciding what people are going to do with their coverage beyond Medicare A and B. So the option on the left, or option 1, I should say, is called a Medicare supplement or Medicare. And conceptually what that means is that Medicare pays the primary insurance. So you have your A and B paying as primary. And then the secondary insurance, the supplement, pays as a secondary insurance that fills in the gaps of what Medicare doesn't cover. A good example of that under Medicare Part B, like if someone didn't take a supplement or didn't take an advantage plan, like they didn't even do anything in step 2, they didn't do A and B step 1, they went into, let's say, a doctor's office. They're going to be billed 20% co-insurance under Part B after a $257 deductible was met. They're now responsible for 20% of anything on outpatient. So doctor's visit, let's say they go in and they get billed for $1,000. 20% of the $1,000 is $200. So they're going to be billed $200. Medicare would pick up the other 80%. So Medicare would be billed $800. Let's say they had to go to the emergency room and they were billed $10,000. Just like that, now they're billing $2,000, 20%. So you're talking about chemotherapy, things that could be potentially large out-of-pocket costs. That could add up really quickly if somebody was really using their coverage. So basically, the supplement, if you chose a supplement plan that would fill in that gap, instead of the patient being billed that 20%, instead it's being billed to the insurance company that they do. So the thing that's awesome about a supplement plan is that the member ends up with little to no out-of-pocket costs. So you guys in the community may have heard, for example, of like Plan G or Plan F is in Frank. Those are going to be Cadillac plans. So those are like the plans that cover pretty much all out-of-pocket costs. cost. So when I have somebody that comes to me and says, you know, I get an infusion of food or it works great because they pay a monthly premium for the supplement. And usually those premiums are anywhere from about 150 to 250 or so per month. And the reason I give that range is because it can vary based off of your area, your age, and your gender. So that can fluctuate depending on what plan you choose, what insurance company you go with, and also it usually will go up as people get older, as well as the cost of living. So again, there is an extra monthly premium on top of that $185 for the per fee. So again, we have that $185 for per fee. We go the supplement direction, usually about 150 to 250, but it works really, really, really great for people who really need it. The other thing to keep in mind if we do go the supplement route is that the drug plan, which is at the very bottom on the left of page 4, the Part B, D is in drug, is the only acronym in Medicare that makes any sense. But it is a separate policy. So in which case I would, just kind of run people's medications and just say, hey, this is the plan that matches up best for you with your drugs. Maybe your spouse has a whole different set of medications they take. Let me recommend this other company or this other plan. So it's a very unique and individual choice that we make for people. And then one last thing just to mention, if we do go to Medicare, step 1 or option 1, I should say, on the left direction with the supplement, doctors would have to accept Medicare as primary insurance if we go that direction. Some doctors accept Medicare, some don't. So that's a case-by-case doctor decision that they get to make. But it is nice because there are doctors throughout the country who do accept Medicare. So if I have somebody that says, I spend 6 months out of the year in a different state and I want to see doctors who accept Medicare, I mean, you can find doctors all over the country. Not saying that every doctor does, but you certainly can. So those are just factors, again, that's part of the conversation I have with people. So jumping over to the right side there, option 2, we have the Medicare Advantage plan. So conceptually, the way an Advantage plan works is almost the opposite of what we just talked about. So with an Advantage plan, Medicare pays the private health insurance company a certain amount of money per member per month. And all of that money goes into a big pool. And then the insurance companies from there basically decide what the benefits look like. So because we're in a large metropolitan area, most of the private health insurance companies here in the Denver metro area, and there are a lot of them, but do offer like a 0 premium Advantage plan. And so what that means is that outside of what somebody has to pay for Medicare Part B, that 185 plus run, they don't have to pay anything extra for their Advantage plan. The first thing that anybody ever says when they hear that is, how do you get something from nothing? Like, how could that even be, right? It's because we are in a big area that reimbursement from Medicare to the insurance companies is enough that they can offer that. And quite frankly, the insurance companies have to stay competitive with one another. So most of the insurance companies do offer pretty, good benefits in that sense. Now, if you were to maybe have a client or a family member in a different area of Colorado, maybe more rural area or Eastern Plains, or even out of state, there may not be any or maybe much fewer options, and so it is case by case situation. So what we're talking about right now is kind of more Denver metro. I mean, obviously we're in Arapahoe County here now, that's what we focus on, but people do kind of transition in and out. And also something to keep in mind too, a lot of people who work with people coming and going from Colorado, Jan and I were just talking about this before the meeting today, when somebody moves, they actually have to change their insurance to whatever the new area is. So for example, Jan was just mentioning she has somebody in her facility that just is moving from Florida to Colorado. Legally, they have to change their plan within 63 days of their move or changing their address. So like her client or her resident needs to change their insurance to something here locally. So I'll be helping them to do that. That is a special enrollment period. So we're right now in the middle of March or near the end of March, I guess. If you want to turn to page 7, just real quick, I just wanted to talk about enrollment windows and then we'll get into the Medicaid stuff. So this is just kind of like the Medicare calendar, so to speak. And so at the bottom of page 7, I was just mentioning there are special enrollment periods that allow people to make changes throughout the year. So moving would be an example of one. Before I was mentioning people like working past 65 and retiring, that would be another. Loss of group coverage is considered a life-changing event or a special enrollment period. So people ask me what I do when I'm not in open enrollment. This is the kind of stuff that I'm doing right now because we're not in open enrollment. And also, of course, people turning 65. So the special enrollment periods, again, are going to be year round. You can kind of see some bullet points there on those. But for somebody who's turning 65 and starting Medicare for the first time, that also would be a year-round enrollment period because people's birthdays are throughout the year, right? So they basically, let's say you would know somebody who is turning 65 in August. So their 65th birth month would be the start of Medicare. So August 1 will be their Medicare start date. They get 3 months before their start date. So that would be July, June, May. May 1st is the start of their 3-month window prior to their birth month. They get their actual birth month, and then they get the 3 months after. So they technically would get September, October, and November to create a whole 7-month window that they can sign up. Now, ideally, you try to do that on the first 3 months leading up, just to make sure that you have coverage on the, when they're eligible. But, sometimes people procrastinate or forget, so that's what the GO3 chart is on the other side. So the other 2 enrollment windows I just wanted to chat about real quick are the students. Sorry, yes, please.
Ignore me.
No, you're good. I'm glad you said that. So the other enrollment windows, the first one on page 7 here, the annual enrollment period. This is the big one. This is the one you see all the ads on TV and your clients get all the phone calls and everything. So October 15th through December 7th, that's basically where you can kind of make any change that you would want as many times as you want. I mean, sometimes people say, oh, I want to switch to Humana. Oh, wait, I changed my mind. I want to go with Pfizer. So, we could definitely do that. But whatever is decided by December 7th is what the plan will be. So it's a really important time. People's medications could have changed within a year. People's doctors could have changed, that type of thing. So we really do, have to kind of look at, what to do during that annual enrollment period of what's going to make the most sense as far as coverage goes. And then the other one is the Medicare Advantage open enrollment period. So that's actually what we're in right now. And most people don't even really realize it. We're legally not even able to, advertise it or really talk about it. Like if I have somebody calling me right now and says, oh my goodness, I didn't make a change during open enrollment and I found out my doctor, the annual enrollment period. My doctor doesn't work with my insurance anymore. What do? We have a one-time plan change that we can make between January 1st and March 31st. So we're like literally a week away from this, this is the last chance. So again, if you know of somebody who's like scrambling and wouldn't have a special enrollment period, we really can't do anything until this fall unless we make that window. So timing is perfect in case you do, have anybody in the next week you run into, please feel free to loop me in. So real quick, I just want to kind of go back to page 4 because I didn't talk too much about the Advantage plan. And the reason I want to kind of go through that and then kind of segue into the Medicaid piece is because Medicare and Medicaid can work pretty well together. But before we talk about that, I just wanted to just, again, give a little bit more of an overview about the Advantage plan. So I mentioned before with an Advantage plan, the private health insurance company becomes primary. And so that means rather than doctors billing Medicare plus a supplement, instead they're just billing the insurance company. So if you know somebody who has, let's say, a Cigna Advantage plan, they're going to doctors that work with Cigna and are going to be billing that. So they don't bill Medicare. The pharmacy, the doctor's office, the hospital, the emergency room, all of that bills the private health insurance company. And then what happens with the Advantage plans, and we talked about this before, generally the premiums are going to be lower, and then the patient just pays co-pays as they go. So one of the things that is nice about an Advantage plan is that for somebody who doesn't use their coverage much, but wants to make sure they have protection if something catastrophic were to happen, you have built-in flat co-pays. So for example, specialist co-pay is usually maybe anywhere from like $10 to $50. Primary care is usually $0. Emergency room is maybe 150 to 200 or so. So you have your plans termed, so you know exactly what to expect. So there's never any like, it doesn't matter if somebody has an outpatient surgery that's billed for $10,000 or $80,000. If their copay is $250, that's what all that matters for them. So it is nice because you do have predictable costs. The other thing is that the drug plan is included with the Advantage plan. So that's nice too, because it's all bundled with the private health insurance company for medical and drugs. So it's like one card for everything, which makes it a little bit easier. And then lastly, there are going to be a lot of extra benefits like vision, dental, hearing, things like that. So Medicare itself doesn't typically cover much of those categories. So if somebody's like, you know what, I'm pretty healthy, but I have a lot of dental issues, sometimes prioritizing a good dental plan with maybe an Advantage plan might be something to look at too. So again, no right or wrong for anybody. The worst thing that anybody ever says to me is like, my neighbor said that this is the best plan in the world and I have to get it. And I say, I'm glad your neighbor's happy with that. However, what is your situation? How often do you go to the doctor? What are your medications? Do you travel? You know, that type of thing. So all these factors that we need to kind of take into consideration. But and the last piece I wanted to say, and just kind of in general to our segue into the Medicaid piece, is a lot of the private health insurance companies will offer what are called dual plans. Dual is for Medicare and Medicaid. So sometimes when people get Medicare and Medicaid, one option would be to have Medicare as the primary insurance and then Medicaid as the secondary, which works out great because between the two, they basically cover all medical co-pays. So at a minimum, if somebody qualifies for Medicaid, we're like, yay, this is awesome. Because these are folks that really are going to need, you know, they probably can't afford a medical copay of $300. Sometimes what we'll also consider, and this is again a case by case situation that I talk with people about, a dual plan, which means that the private health insurance company is added into the mix with an Advantage plan. And a lot of times what happens with that is that the private health insurance company can offer extra benefits in addition to what Medicare and Medicaid has. So what happens is the private health insurance company's primary, Medicaid still comes in as the secondary insurance. So between the two, they are going to be still zero co-pays as long as the doctors that are being seen accept the private insurance and Medicaid and bill each of those together. But what's the really, you know, big drawing factor to that is that a lot of times there will be things like transportation, pretty good dental. Like sometimes the dental ends up being like $2,000 to $4,000 a year in dental, which is pretty good. In addition to what they get with Medicaid. There's a lot of the insurance companies offer the grocery cards, so you may hear those ads on TV, like groceries, and you know, maybe like $200 to $300, depending on again the insurance company and everything that they can use. They can go and buy healthy food with that. Some of the insurance companies will also send that into utility bills, so like phone bills, gas bills, things like that. So anyways, it's a nice package deal. Again, something one-on-one that we talk with people. Sometimes Medicare and Medicaid is a great combination. We just do that. Other times people are like, yeah, I could really use transportation included in my plan, or that, you know, $150 in groceries would really, really benefit me. So talk about that, but they all just kind of work together. So I guess with that, should we just transition and then maybe do questions afterwards, or do we want to do questions for me now?
Jump into Medicaid.
Jump. All right, here we go. Medicaid.
I thought I knew a lot about Medicare. Turns out I don't. Thank you very much for that. My name is Steve Dash. I'm a supervisor with Arapahoe County Human Services. I supervise one of 3 units that deal with financial eligibility for adult financial assistance, food assistance, and then with me, my priority is Medicaid. Sorry, three microphones don't have very much of a history, so I apologize. I work for Arapahoe County Human Services, supervise one of 3 units that deal with financial eligibility of adult financial, food assistance, and then Medicaid. Medicaid is something that I've really latched on to not long after I first started, and it's something that I made a priority, making sure because it's just a wonderful healthcare program. It's one of the best. And, you were very, very efficient. I'm going to try and. The most common Medicaid is a financially based Medicaid. They're all financially based, called MAGI. It's modified adjusted gross income. And that's where it goes from age 19 to 64, unless you receive Medicare. If you receive Medicare, then you're not eligible for the MAGI. But everybody else is. And it's based on income only. There are only two Medicaid programs that we look at resources. I'll talk about those in a few minutes. One of them is a direct partner with Medicare. So the application process is the easiest way. We have an online application process called PEAK. So if you're interested in that, you can just, I want to say Google it, but Google's not the only search engine. Just go look up Colorado PEAK, and that'll take you to it. You have to register, but you can apply online. You can do your financial redetermination. There's a yearly financial redetermination for all Medicaid categories. You can do that through PEAK. You can upload, like, for example, if you need resources, you can upload your resources through PEAK. So that's a very convenient way. We also have paper applications. The one that I usually send out is like 8 pages long. The official Medicaid application that was launched about 4 or 5 years ago was like 30 pages long. Yeah. So when somebody asks me to send an application, I'm sending them a short one because it basically just everything, they go into a lot of detail on the long one. But this is the hierarchy of the Medicaid. There are 23 different Medicaid categories. And as far as our population, I turned 65 last year, and I thought, okay, am I supposed to feel different now that I'm 65? No. But that's really when I started paying attention to Medicare for myself. But there are 8 categories that work with people 60 years and older. And I'm just going to touch on a couple of those. One of them is the one specifically works with Medicare. It's called the Medicare Savings Plan. And there are 4 different levels of that based upon income. The one with the lowest income standard is called QMB, Qualified Medicare Beneficiaries. It pays for the Part B premium, and it also has additional medical coverage. The one below that is called QMB. Don't ask me what that stands for. And the one below that is QI1. Those are strictly paying Part B premiums. But the really good news about Medicaid is a few years ago, they switched that you had to have a specific 1 or 2 categories of Medicaid to also have your Part B premium paid. Well, now, a few years ago, they switched over. If you have any Medicaid category and you also have Medicare, then your Part B premium is going to be paid by the Medicaid. So that's the nice thing about all Medicaids, because then we don't have to worry about, why don't you have it versus you. So there's that one. There's also a thing called the low income subsidy, which pays the Part D as prescription coverage, right? You pay your Part D. So those are the MSP categories. Then if one of our financial categories that we work with is called old age pension. It's a financial eligibility program for people 60 years and older that make less than, I think the income limit for this year is $1,005 a month. And if you're eligible for that old age pension also is income based and also resource based. So if you're approved for the old age pension, and depending where, what else you want to hire, there is a specific Medicaid directly related to the old age pension. It's one of the 23 categories. So that's the second one. And then the one that it's the most comprehensive Medicaid out there. It's called long-term care. And it's got a lot of different subcategories. The two primary categories, actually, there's three primary categories. The primary one that we see most of is called home and community-based services, HCBS. Like one of the things like Cambridge, here's a assisted living facility, right? It covers, I'm familiar with Cambridge, me and the billing people probably are on a first name basis at this point. Because anytime they have billing issues, we get a new number. So home and community-based services, and then there's nursing facility care, and then hospitalization. For example, with hospitalization, you would have to be in the hospital for at least 30 consecutive days. But then you can transition over to a nursing facility or HCBS once you discharge and you're eligible for that. So basically what long-term care covers, it's about as comprehensive as you can get. I mean, it covers not only assisted living facilities, nursing facilities, it covers hospitalization, doctor's care, prescriptions. I mean, it's across the board, and it's very, very, very popular. And it's something that we want to encourage as many people as possible to apply for, because it's federally funded, state run. The counties, have our own individual offices, but that's where that's at. As far as financial eligibility, like for example, with long-term care, the income limit is, the monthly gross income limit is $2,901. However, one of the things about long-term care is if your income is above that amount, then you would have to create what's called an income trust. It's a formal document that you need to complete, turn it into the counties. We send it to the state Medicaid office, Healthcare Policy and Finance, or HICPUF. If you hear somebody say HICPUF, that's what we're talking about. They generally get those approved within like 30 to 45 days. And then once we get that back and approved, and we have the long-term care, the long-term care, you've got to meet the financial criteria, the 2,901. You've got to meet the Social Security guidelines for having a disability. If you're 65 or older, or receiving Social Security disability or supplemental Social Security income, SSI. If you don't, and you're under the age of 65, you would also have to complete a disability application, which is about 15 pages long, very comprehensive, goes into a lot of detail about medical records, and you send that to a specific agency that they determine whether they meet the Social Security guidelines for having a disability. That process can take several months. The main cause of delay is they have to request medical records, and so it's up to how soon do the providers provide with that. So anytime I send in a disability application, I say, okay, one of the things you might want to do is contact the provider, say, hey, you're going to be contacted by this agency requesting medical records. It'd be really great if you could get to them sooner than later. And then the third criteria is resources. Resources, we're talking about bank accounts, insurance policies. If you own property, like your home, this is an exempt resource. If you own a secondary property, then that's going to be countable value is what we're going to count. And the income limit, the resource limit for long-term care for a single person is $2,000. For a married couple, it's $3,000. And then if somebody is applying for long-term care and they're married and their spouse doesn't have
Where's my
resource limit is
audio?
$150,000.
Volume?
But it has to be sit down by the end of the first year of the eligibility, $2,000. So that's the main thing. That's typically the application process. It's the resources that usually we have to go for. Also, for long-term care, you have to meet the level of care guidelines, which for home and community-based services and nursing facilities, we work with an agency called Development of Pathways. We used to work with an agency called Rocky Mountain Human Services. You're very familiar with Development of Pathways. They're very good partners. We are a very good working relationship with them. It's like, we got a specific email for their management team. They got an email for our management team. We're having a lot of discussions. I get a lot of emails, exchanging emails with them. And so we work very closely with them. And so if somebody says, what's going on with my Medicare, how come I haven't been approved yet? I'm like, well, we're still waiting for the level of care. Tell you what, I'll reach out to the developmental pathways and I'll put you within a week. So that's pretty much in a nutshell, that's Medicare. I tend to not, if you get me started, I can talk all afternoon about all the different facilities, but I'm not going to do that here. But yes. Yeah, absolutely.
She was trying to get the application, 100.2, the long term. She could not get it downloaded to print a copy of it. So she was on the hold forever anyway. So she's like, what's the best way to get in contact and ask about real time? What's the real time to get, getting the functional assessment is taking much longer than it used to. It used to be 90 days for CPS. What is the number? She's asking.
That sounds about right. Part of the issue is there's such a high volume. But, you know, we also have a really good report. And so if we say, you know, we've got this 4 days, one time from now, they'll tell us it's like, this person really needs an everything and sooner or later. We will work with them and say, okay, you know, whatever we have, we're prioritize to do it. For us, is this a provider or is this a clinic? And we're going to do 2 email addresses. The first one is our unit has an inbox, which is worked daily by the supervisors, anyone twice a week. It's adult financial long-term care. One this is still like
Is that LTC or long-term care?
it's the full works. Yeah, it's you talk about like you really need to ask these guys or IT guys to change it to their own to just that. Once you get the first time, it's I'm also going to give you my email. I don't have my email address. I don't want to do. So my email address is snash SNASH So the units, that's where I recommend you try first because if we work the inbox emails, the next business. And the first thing that happens is we have a group of our business associates who go in and somebody sends their documents. The first thing they do is they'll take the documents and they'll upload it. They'll do it digital database and all that documents go into. And then therefore else to say, hey, social worker, I have this claim, fire, I have this claim, you really need to get a service sign, I've got to get some detail, and also, they won't need to. But I did it, which is pretty, right now we've got something like almost 2 months left from each other. Yeah, one of the things I do like later in the week is I'll go in and I'll look at the Google documents and then I'll go in and look at the written documents that we received like or last summer. And most of those are something that having eligibility related effects to, so that we will have this out of anything. But you know, if you're a provider, if you're concerned and you go, you know, I really need my services to start, you know. We also got a call center number for others. We'll do that. It's 636 1170. That goes to a call center. They can answer the call center. The call center workers aren't program specialists. They know minimal about the programs. And we talked about all of it, not just Medicare, but financial assistance, children's assistance, food assistance, which is most of the problem, food assistance. But they'll talk to them, and then if they can't answer their questions, then they create what's called a ticket. And each unit has a 20 database for these tickets. And those are worked daily like a fire unit. We have 3 program specialists work that every day. So they should get a response. And the deadlines are usually a week. And lots of times it may take up to that week because of the backlog. But if they determine that it's critical, then it will that's pretty much everything. Okay. It's a great program, and I can't say enough positive things about it. They have a very supportive. They back in March of 2020, they walked in long-term care, and people were just very, they just specific. They walked in unless they, moved out of state or died, they haven't made the comments to the eligibility. Well, this year they're just now starting to break the law. And people walked in the first 5 years. And even now, there's a transition period. So, like, we have a monthly redetermination, financial determination. And before, we really didn't need anything. We just did it automatically. Now, you have to get, the financial verification again, bank statements, stuff like that. And if somebody is no longer financially eligible, for example, for long-term care, they'll get a 2-month extended period. Like, for example, if their redetermination is this month and they determine not to be financially eligible, the Medicaid wouldn't close. This is just specifically for long-term care. Wouldn't close until the end of May. And so you would have until the end of May eligibility. So that's been one of the best things that have happened. Unfortunately, why it happened was awful. But HICPUF really stepped up and helped out the family. So I can't say enough good things about that.
And I actually will add to that too. If somebody loses their Medicaid, which happens, that actually triggers a special enrollment period for Medicare, because then, like, for example, if they're on a dual plan, we would want to move them from a dual plan to like either a supplement or like a more traditional Advantage plan too. So it's happening, unfortunately, with this redetermination and everything. Yeah.
And Medicaid is payment of the last payment. So, for example, if somebody has private health insurance and Medicare, private insurance gets billed first. Whatever they don't pay gets billed to Medicare. Whatever they don't pay, that's when Medicaid steps in and pays the remainder. So that's where we are on the Medicaid. Yes.
Hi, actually, I'm Barbara Bork, and I work with Skipton Reynolds, who's an estate planning attorney and does Medicaid income trust. What's your opinion of the funds that are coming out, or won't come out from Washington? Federally funded payments from the federal government for Medicaid.
I don't know. I mean, number one, I can't believe they're even thinking about it, because healthcare coverage is such. I mean, one of the reasons why I focus so much on Medicare or Medicaid is health coverage should be a priority just overall. And so I can't believe they're even thinking about it. And that's all I'm going to say about that as far as sharing my opinion. But we will, I mean, like I said, HICPUF is incredibly supportive. So I'm sure that I'm sure they're probably already looking for additional funding sources. I mean, I keep checking several times a day. Is there anything new about this? I haven't seen anything new about it since they announced it. The only other thing I'll say is I'm really glad we have a judicial system in our country. And I think that's slowing them down quite a bit. So I have no idea what's going to happen if they actually follow through with those cuts. All I know is the state Colorado will do everything they can. And we will at the county level do everything we can to keep people on the medical coverage. So.
It's almost like he was trained by the county what to say. Just kidding. Other questions? No? Okay, well, I know we have one online and then I have several. Okay, it's still working. So online, Irina is asking a question to Steve. People who are applying for OAP are required to apply for SSI, SSD, and retirement scheduling and appointment is very hard to do now. County is asking 10 days for return paperwork. I'm not sure what the question is, but do you understand what they're saying?
Oh, absolutely.
Okay, I'll let you speak to it.
What that means, we need proof that you've applied for it. We know that getting an appointment with Social Security is going to take a while, but all we need is acknowledgement, and it has to be specifically reference SSI or Social Security disability or Social Security retirement based upon the person's age. You just need a letter saying that we've received your application, and that's it. It just has to be specific about, it has to list at the top SSI or supplemental security income, SSDI, Social Security disability insurance, or Social Security retirement. So that's what we're looking for. And then we have to get an update at your every financial determination. So we have to get an update on that.
Hello? I hope that answered your question. Does anybody else have any questions online? You can put them in the chat or unmute.
Hi, can you hear me?
Yeah, we can just barely hear you.
This is Irina. Steve just answered my question, the one I asked. Everything is clear. The only question I do have with ESSA, to apply for SSI, you cannot do it online. You have to have, literally have to be able to get a hold of somebody at Social Security office and them to schedule an appointment. They do not send you any type of verification or anything like that. And sometimes they don't even call you on the date and time when they're supposed to. So like retirement, you can do it online. Disability application, you can do it online. But SSI, there's no way of doing it online.
I did not know that. There's also, we have an interface with Social Security, and so once they've entered an application in their system, we can look it up. We look up the claims by their Social Security number, and it will list, if they've applied, they will list an application date. And if they at some point deny it, they will list the denial date, and they'll have a code for the reason why they denied it. And we have a template, it's not a template, but we have a tool that lists all the different codes for denials. So we also can use that for SSI. If you don't have a letter, we can verify that through the interface that we have.
And Irina, Kia, correct me if I'm wrong. We have a couple contacts at Social Security over at Senior Resources over at Arapahoe County that we could contact directly or give you their phone numbers. We got them from Human Services. So you can call our general office line at 303-738-8080 and just ask for our Social Security contact. We have that on our resource list.
Yes, I'll look that up and share that now, and that's correct, Courtney, yes.
Okay, you'll just put it in the chat. The general line is 303-738-8080. And Keel put the number in the chat, and I can share it with you guys.
Awesome. Thank you. One more thing, one more last question I do wanted to ask. I work with a lot of people who are either have a green card or they are citizen, but they never worked in the United States, not even, one day in their life. So the question I have, this is where it comes, they're not eligible for retirement and disability, they're over age of 65. So it will automatically be denied for them. Do I still have to go through, submitting applications online?
Something good that we just clarified at the county level just literally last week is if somebody's 65 and they're receiving either SSDI or Social Security retirement, they don't have to apply for the other one. Our system doesn't quite read it that way, so but we had to talk at the management level with our unit. And so it's a start. So if you're over 65, and then also if you provide us with a letter from Social Security saying you're never going to be eligible for this in so many words, then we shouldn't have to ask you anymore for proof of applying for those. And if you do, and you have issues, let somebody know to contact us. I'm always available for situations like that, if nobody else, but yeah, reach out to management and we'll look at this specific case.
Awesome. Thank you very much.
You're welcome.
All right, thank you. I have a couple of questions. Well, since we're on Medicaid, I'll just start with my Medicaid question. So this is just clarification for me. So as senior resources, when we have someone join our homemaker program, because that is a qualifying HCBS program, if someone is on Medicaid long-term care, they can't also have our homemaker program because they're funded by the same grant. So we have verification through the county that they don't have long-term care. But I just want to clarify, so Human Services will help individuals apply for Medicaid long-term care, but Developmental Pathways does the eligibility. I just want to see where's the connection between the two.
I don't know how to do this.
Okay, Developmental Pathways in the past have had a caseload where they do help. We get applications from them, and I think they might still have a portion that still does that, but they transition to primarily being the level of care approval agency. They don't provide us with applications anymore, which is too bad because applications we got from Developmental Pathways, they were ready to go. They had everything we needed because they knew what we needed. So our current relationship with them is specifically with, they do the level of care assessment and reassessment. Because when they do level of care, they do them for basically 12 months at a time. And so not only do you have to have a yearly financial redetermination, you also have to have a yearly level of care assessment through them.
Okay, so just when I'm referring individuals to apply for Medicaid long-term care, I should just tell them to go to Peak or walk into a county office, not give them Developmental Pathways number.
That probably would be the best.
Best, okay.
Yeah.
Okay, thank you. You already answered that. The home is exempt for Medicaid, so I think that answers that question. Okay, now I have questions for Krista. Sorry, just two quick questions. So, my mom just recently turned 65 and she went to a training on like how to enroll in Medicare, and she was told that the plan you pick when you turn 65 is the plan you have for life. And I don't believe that. So can you talk about kind of that language or what they're saying, why that's being?
That's a good question. I could only think of one. So with Advantage plans, those can be changed during the annual enrollment period. So that's real easy. No pre-existing conditions as long as you have Medicare A and B and live in the county that we're looking at applying into, whatever that plan that is, not a problem. Maybe what she's talking about was the supplement, and that was option 1 on the bottom left of the diagram. The supplement, you legally are guaranteed acceptance into within the first 6 months of starting Medicare. So that could be either at age 65, starting Medicare A and B, and then you legally, all the insurance companies have to grant access into the supplement with no health questions asked. Or if you delay your Medicare and activate your Part B, let's say at age 68, 69, that's your same 6-month window would start, or be the 6 months after that. Once that 6-month window is passed, the insurance companies can ask pre-existing health condition questions. So that it's a common misconception. If that was what the presenter was telling people, that you're stuck forever with whatever you choose, then that was definitely the wrong information, which unfortunately in my industry happens. A lot of misinformation, as I'm sure in yours as well. But yeah, and we do talk about that with people when they're choosing. Sometimes I tell people, if you think big picture, you want a supplement or a Medigap plan, we probably do want to really seriously consider that right from the get-go, because you're basically grandfathering yourself into it. Somebody at 65 goes into an Advantage plan, real healthy, and then, 3 years down the road calls me up and says, hey, Krista, let's switch to a supplement plan. We can look into doing that, but one, it would have to be during the annual enrollment period, October 15th through December 7th. And second, we would have to go through those health condition questions, and every company does their health conditions differently. But the one thing I always tell my clients is any of us could wake up tomorrow with a pre-existing condition. I mean, knock on wood. So if that happens and it goes on your medical record, that could completely eliminate the ability to ever get into a supplement down the road. So that is something to consider.
Thank you. And then I had a question. So you mentioned that individuals who have a disability can qualify for Medicare. Are there income restrictions to that, or it just has to be a disability or things? Can you talk about eligibility for that?
Yeah, that's a really good question. So disability, the actual qualification itself is the court process, meaning that they go through the whole legal system and they're granted disability, which usually gets the SSDI. So as far as age group, no, I mean, there's really, as long as it's granted, then they get their Medicare 24 months later. Sometimes that does end up going with Medicaid. If somebody was planning to work most of their life and then is disabled and can't work anymore, a lot of times that triggers them being of an income level that they likely could, qualify for Medicaid. So in which case, sometimes we'll look at those dual plans too, as a combination.
Is there an over income and then you're disqualified from the plan, like disability?
She was asking if there's if you go over a certain income amount, could you be disqualified? No. I mean, you could be any income level and get the SSDI. It's mainly just the health insurance. And I think the logic behind it would be, when somebody's working, they have access to their health insurance through their company. But if they can't work because of a disability, now they need to get insurance. And so sometimes that could be through the exchange, which is a whole different area of insurance that is not my area of expertise. But also, I think the theory behind it is, if somebody can't work anymore, we want to give them an ability to get some sort of insurance. And so Medicaid is one of the solutions as long as they're able to qualify.
Can I add a couple of things?
Yeah.
For people who get approved for supplemental security income SSI, which is basically for people with no work history, there's a specific Medicaid for that. So if you get approved by Social Security for SSI, then you're going to get approved for SSI Medicaid as well. So that's one of the main categories. And then I just wanted to clarify, make sure that I've been telling people right. Somebody gets approved for SSDI, the Medicare doesn't kick in for 2 years. Is that correct?
Usually, I mean, if something else happens, great, but I always just tell people expect it to be 24 months, 2 years. Yeah. It could happen.
All right, and it looks like Kia did put that number in the chat, and Kim also added that they can call beneficent, and she put that number. I can leave this up for you guys later. Any other questions? Otherwise, I'll end the hybrid, and then we can just kind of do some networking and introductions. No? All right, sorry, my phone's the one that's ringing. All right, well, thanks everybody for joining us. Oh, wait. Oh, yes, okay, Kim's talking about beneficent, so, oh, okay, well, we'll end the Zoom, and then thank you guys so much. Like I said, I got to watch Krista in action, it was amazing, and I mean, Steve works at the county, so basically related, just kidding. So thank you guys so much for your help, and if questions do come up, you can always email Joe, who just had to step out, and we can always get in touch with these two again, so thank you. Do we want to take a minute to get cookies and milk before we do networking? Okay, so we'll pause and we'll come back in like 5 minutes. Awesome, thank you.
Yeah, for sure.